to measure the blood pressure by using a sphygmomanometer, which is an aneroid type. So there are different types of blood pressure machine. I guess all of you know different types of blood pressure means different types of blood pressure machines. One is aneroid sphygmomanometer, another is mercury sphygmomanometer, another is digital sphygmomanometer, right? So there are different types of blood pressure monitoring devices. So if I ask you how can we measure blood pressure, so the answer should be yes, blood pressure measurement can be invasive or non-invasive. So during my theory class, during my lecture class, if you have attended, if you remember that we can insert a cannula directly into the artery and measure the blood pressure, right? I can insert directly into the aorta and connect it to the manometer and take the blood pressure. Very accurate, okay, but it is invasive, okay, it is invasive procedure. We don't do that, okay. Particularly in OPD setting, we can't do that, okay. Maybe in ICU setting, sometimes we require measurement of direct arterial blood pressure, pulmonary arterial pressure. Invasive means you need to do some puncture, okay, invasive procedure, okay. Like say for example ECG. ECG is a non-invasive procedure. That means you don't need to cut or puncture or no needle, no knife, right. But for invasive measurement of blood pressure, you need to puncture, okay, you need to cannulate the artery, right, and take the reading by attaching a sphygmomanometer. Non-invasive means no injury, no cut, no puncture, right, okay. So blood pressure measurement can be invasive, can be non-invasive, okay, and mostly in OPD settings, in outdoor settings or in the office, in the doctor's clinic, we use non-invasive method, okay, because it is convenient. So blood pressure measurement can be invasive, can be non-invasive, and out of non-invasive you have three different types of option. One is digital sphygmomanometer, one is mercury blood pressure monitor, and another is aneroid, okay, this ghadiwala, right, okay. So there are these different types of blood pressure measurement ways we have, but today we will learn blood pressure measurement using aneroid sphygmomanometer, okay. Okay, what is our learning objective? To be able to measure blood pressure by palpatory method, auscultatory method, and correlate clinically. Okay, this is very much important. We need to correlate clinically, right? Tie the blood pressure cuff properly around the arm of the subject and detect the appearance and disappearance of Korotkoff sounds by placing stethoscope on the brachial artery. By placing stethoscope on the brachial artery, right? On the brachial artery while measuring blood pressure. Okay, I am coming to it. What is Korotkoff sound? Aneroid sphygmomanometer, and under aneroid sphygmomanometer blood pressure measurement, we have again two different types of method. One is palpatory method and one is auscultatory method. In palpatory method, we do not use a stethoscope. Okay, in palpatory method, we do not use a stethoscope, but in auscultatory method, we use a stethoscope. Right? I am coming to it. What is the procedure? So, what is the principle behind it? The principle of measuring blood pressure using aneroid sphygmomanometer is that it has got a metallic bellow, okay, and the pressure within the cuff is matched against the pressure within the bellow, right. So, blood pressure measurement by a sphygmomanometer involves balancing the air pressure against the pressure of blood in the brachial artery and the air pressure being estimated by a mercury sphygmomanometer and by a mechanical system of metal bellows within the aneroid sphygmomanometer, right. So, within this there is a series of metallic bellows, right, and we raise the pressure with this pump or inflator, we call it inflator, right. We increase the pressure within this cuff and we match the pressure inside it with the pressure in the brachial artery, right, and this is how the blood pressure is measured in brachial artery, right. So, what apparatus is required? Aneroid sphygmomanometer, a stethoscope, and a chair and couch for patient, right. Okay, this is the left one is aneroid sphygmomanometer and this one is mercury sphygmomanometer, okay, aneroid sphygmomanometer and mercury sphygmomanometer. Okay, now the cuff size, the standard you should remember, okay, the standard size we will ask you in viva examination. So what is the size of the cuff, blood pressure cuff? Okay. So blood pressure cuff in centimeter is 12 into 26. 12 into 26. Do you think this is 12 into 26? No. So this is larger or smaller? Larger. No, this is also 12 into 26 because it says the measurement of the bladder inside. Okay, inside we have a bladder, right? This is 12 into 26. Okay. So this bladder, if I inflate it, okay, so pressure will rise inside, right? This bladder. If I release it, ज़्यादा टाइट हो गया. ठीक है. So this is the cuff जिसका मेजरमेंट हमें वाइवा में पूछा जाता है. Not this one. Okay, this is the fabric. Okay, this is the fabric, and this one is the bladder cuff or BP monitoring cuff. Okay, the dimension we ask is of this one. Okay, so the standard dimension for most adult is 12 into 26 centimeter. For obese adult, it is 12 into 40 for those obese, right? As a newborn, infant and child, you may remember, but we usually do not ask in physiology. It may be asked in your pediatrics, right? Okay, but definitely we will ask the standard cuff dimensions, right? That is 12 into 26 centimeter. Okay, so next I'll put it inside. Okay, someone please go to the office and take another BP machine, right? Other than this. तो ना मैडम के बोल. Okay, so I will start with the procedure. The procedure is palpatory method and auscultatory method. Okay, palpatory method and auscultatory method. Palpatory method means what does it mean? Palpatory means palpation, to feel, right? Palpation means to feel, and auscultate means to hear. Okay, to listen, to hear. Okay, so definitely in auscultatory method we need the help of a stethoscope. And palpatory method, we need to feel the pulse, right? Okay, what precautions is to be taken? Very frequently asked in your viva examination. What precaution you will take while measuring blood pressure of a patient? Okay, a patient is coming to your clinic, right? A patient is coming to your clinic and you want to measure blood pressure. Should we do it immediately? The patient may be coming by walking, or maybe the patient was in a hurry, right? So we should not measure pressure immediately, right? Okay, so there are different precautions. So first is make the patient rest for at least 5 to 10 minutes, which is required ideally. It may not be possible in a crowded OPD like ours or in a government medical college hospital. Okay, it may not be possible very often, okay, due to huge load of patient, but what I am telling is the ideal condition. Okay, so ideally the patient should wait for a period of 5 to 10 minutes in rest, then we should start the measuring of blood pressure. Okay, so next is the area where we will tie the cuff. Okay, the cuff should be tied over the brachial artery. Okay, over the brachial artery, and it should not be too tight or too loose. The cuff should not be too tight or too loose. Okay, some volunteer please come over here. what I am telling is the ideal condition. The ideal condition may not be achieved over here. Okay, so ideal condition, patient should be at rest for 5 to 10 minutes, I told. Patient should not have tea, coffee or alcoholic drink within 4 to 5 hours of measuring blood pressure. Okay, and if the patient is wearing sleeves, okay, sleeves, full sleeve or half sleeve, sleeve should not be rolled out. Okay, sleeve should not be rolled out. Okay, ideal condition is you should remove clothings. Ideal condition. Ideal condition is you should remove clothing, but it may not be achievable everywhere. If the cloth fabric is thinner, we can measure over. Okay, but definitely we should not roll the sleeve, because that roll may constrict arm and create extra pressure on brachial artery, right? So we should not roll. It again comes as a question, right? Remember. Next is cuff should not be either too tight or too loose. If I tie the cuff around patient's arm, okay, so I am tying it over the patient arm. I am still telling it is not the ideal condition because the sleeve is rolled up over here. Okay, it should not be rolled. Okay, okay, so it should not be rolled. If the cloth is or the fabric is thinner, you can tie over the cloth. Otherwise, the ideal condition is always remove clothing. Okay, okay. Now tying the cuff. Okay, now it tells that at number 2 point, the cuff should not be too tight or too loose. Khub tight hobe na, khub loose hobe na, so that you can easily insert 2 fingers inside. So that you can easily insert 2 fingers inside. Okay, it should not be too tight or too loose. Second, the pressure should fall by 2 to 3 millimeter of mercury per second. Okay, so what I will do while measuring blood pressure, I will raise it. It is at 0 right now. Okay, so I will tighten the screw over here. Okay, and I will raise. Okay, during raising, 10 millimeter of mercury per squeeze. 10 millimeter of mercury per squeeze. So I will raise it to up to 160, and while deflating, I will release the pressure at a rate of 2 to 3 millimeter Hg per second. Number 3 point, right? So I will release it at a rate of 2 to 3 millimeter of mercury per second. Clear? Okay. So while inflating from 0 to 160, I will raise at a rate of 10 millimeter of mercury per squeeze. Okay. তাহলে 0 থেকে আমাকে যদি 160 তুলতে হয়, তাহলে 10, 20, 30, 40, 50, 60 এরকম করে আমাকে তুলতে হবে up to 160. ঠিক আছে? Again I am telling, in crowded OPDs, the ideal condition may not be achievable. Okay? Because you are in a hurry to serve lots of patients, maybe 100 patients in a day, right? So always I am telling the ideal condition. So ideally the pressure should be raised at a rate of 10 millimeter of mercury per squeeze or per second. Okay, and while releasing, you release slowly 2 to 3 millimeter of mercury per second, right? This is the ideal condition, and the cuff should not be tied for long period with raised pressure. Okay, so if I do it 160 mein maine chada diya or fix, what will happen? Blood supply will be cut off. Okay, blood supply will be cut off. Again, you know what is ischemia, what is infarction, right? Okay, so digital ischemia. Okay, fingers, digital ischemia may happen. Okay, so we should not raise it for a long period of time and keep it as such. Okay, next. No. So assumption. Okay, say for example I am raising it to 160. Okay, I am raising it to 160, and gradually I will slow down and I will listen at what point the sound is appearing. Okay, let me first explain the auscultatory method and palpatory method, then everything will be clear to you. Okay, so now first check the procedure. How to check the procedure of blood pressure measurement? So first, palpatory method. Palpatory method means we will not use 1 second, you have to go and take one stethoscope for me. Or if you have, anyone is having stethoscope with you? No. Please take one from Tuina ma'am. So in palpatory method, first we will see the patient, whether I am suspecting high blood pressure in this patient or not. So this patient may be 18 to 20 years old, okay, a young boy, right? And usually I am not suspecting he or she will be having high blood pressure. I am not suspecting, okay. So I am suspecting his blood pressure will be in the range of maximum up to 130 or 140 and diastolic maybe up to 85 or 90, okay, not beyond that, okay. Okay, so first I will check the palpatory method. So in palpatory method, my assumption is his systolic blood pressure should not cross 140, my assumption, okay, by looking at the patient. And I have already, when I do blood pressure measurement, I have already taken the history from the patient, okay, I have already taken the history of the patient. So do you know clinical examination sequence? Maybe sometimes I have told you, the clinical examination sequence, that means when a patient is arriving to your clinic, first we need to take the history, okay, first, this is the first job, whatever, irrespective of the systemic involvement or irrespective of the disease of the patient, for any patient we take the history first, okay, what is your problem, आपका problem क्या है, ठीक है, so we take the history. History means, say for example, someone is having chest pain, ठीक है, so आपका chest pain कब से है, ठीक है, और is there any aggravating factor कि वॉक करने से चेस्ट पेन बढ़ जाता है या फिर कुछ हेवी वॉक करने से चेस्ट पेन बढ़ जाता है, ठीक है, या फिर कुछ सीजनल वेरिएशन है कि नहीं, विंटर में आपका चेस्ट पेन बढ़ता है, ठीक है, तो इस टाइप का आपका स्मोकिंग हैबिट है कि नहीं, अगर स्मोकिंग हैबिट है तो दिन में कितने सिगरेट्स आप पीते हो, राइट. सो दीज आर द हिस्ट्री टेकिंग, okay. After history taking, we go for general physical examination, okay, for any patient. The patient is having headache, if the patient is having headache, you need to explain the headache in history, details of headache you need to inquire, right, okay. Or the patient may be having respiratory distress, okay. So whatever be the symptom of the patient, first you need to take the history, detailed history, ठीक है. रेस्पिरेटरी डिस्ट्रेस अगर है तो ये विंटर में ज्यादा होता है कि समर में ज्यादा होता है, मॉर्निंग में ज्यादा होता है कि नाइट में ज्यादा होता है, फैमिली में किसी का है कि नहीं, ठीक है. सो दीज आर ऑल हिस्ट्री, ओके. आफ्टर हिस्ट्री टेकिंग वी गो फॉर जनरल फिजिकल एग्जामिनेशन, okay, it's called GPE, general physical examination. So what do you do under general physical examination? Under general physical examination, we check some points like whether the patient is having anemia or not, cyanosis, jaundice, clubbing, edema, neck vein, neck gland, temperature, oxygen saturation and blood pressure. So blood pressure is a component of general physical examination. Okay, you need to remember all the points. After history taking, we do general physical examination, and under general physical examination, the points are anemia, cyanosis, jaundice, clubbing, edema, neck vein, neck glands, temperature, pulse, oxygen saturation, blood pressure. Okay, total 11 points. I repeat: anemia, cyanosis, jaundice, clubbing, edema, neck vein, neck gland, okay, oxygen saturation, pulse, temperature, blood pressure, okay. So these are included under general physical examination. Also remember, in your first professional MBBS syllabus, every item under general physical examination we need to take the class separately, okay. How to check anemia is a class, how to check cyanosis is a class, right. General physical examination itself is a big topic, and it is included in your syllabus. So you need to know how to check anemia, how to check jaundice, how to check clubbing, okay, how to check neck vein, neck glands, okay. These are under your first professional MBBS syllabus. So under general physical examination, one item is blood pressure measurement, and this class is today. Getting my point? And after general physical examination, we do systemic examination, okay. So the sequence of examination of a patient is first history taking, then general physical examination, then systemic examination. What is systemic examination? If the patient is having chest pain, I will check patient cardiovascular system and patient respiratory system. If the patient is having headache, I will check the patient nervous system. If the patient is having abdominal pain, I will check the patient's abdominal, then cyanosis, then jaundice, then edema, then neck vein, then neck glands, okay. Then some vital signs like oxygen saturation, pulse, temperature and blood pressure measurement, right? Okay. So first is the palpatory method of blood pressure measurement. How we can measure blood pressure by palpatory method, matlab to feel. So first I need to check the patient pulse. Okay, I need to check the patient pulse. Yes, I am feeling the pulse. Okay, I am feeling the pulse. So this pulse is on which artery? Radial artery. Okay, so you know how to measure pulse. Pulse class is done, right? Pulse class is over, but I will again take a theory class on pulse because there are different types of pulse. Anyway, this is beyond our topic. So I will check the pulse. Yes, I am feeling the pulse. Okay, it's beating. Now I am feeling radial artery, right? And this radial artery is a continuation of brachial artery. So now what I will do, I will raise the pressure in the cuff. So what will happen? Brachial artery will constrict and ultimately collapse, fully collapse. Okay. So I will block the radial artery, brachial artery. Still feeling pulse, it is 60, 100, still feeling pulse, 130, I am not feeling pulse, no pulse, 160, no pulse. Okay. So I am well above his systolic blood pressure, no pulse, right now no pulse. Now I will gradually release from 160, gradually come down from 160, 150 में आ गया, no pulse, 140 आ गया, no pulse, 130 आ गया, no pulse, 124, yes, starting of pulse, 120, yes, increasing in volume, okay, 80, yes, pulse, and now 0, yes, pulse. So his systolic blood pressure is 124, okay. Isolate. So systolic blood pressure in palpatory method is 124 millimeter of mercury. Okay. So I will raise blood pressure well above the expected systolic blood pressure and gradually I will release, and definitely when I am well above the systolic blood pressure, I will not feel any pulse because the brachial artery is blocked. So radial artery, no pulse will be coming to radial artery, right? Now gradually I will release, from 160 coming down, at 124 I am first feeling pulse, right? So this is systolic blood pressure, okay, in palpatory method, and I cannot determine diastolic blood pressure in palpatory method, okay. I cannot determine diastolic blood pressure in palpatory method, okay. So to measure diastolic blood pressure, I need to take the help of stethoscope, right? So what I will do, again I will do the same thing, but I will not feel the pulse, okay. So I will put it over here on the brachial artery, okay, and again I will raise the pressure well above his systolic blood pressure, and I already know that his systolic blood pressure is 124, okay. So I am raising it 20, 40, 120, 140, 160, okay. Now from 160 I am coming down, no sound, 150, no sound, 130, no sound, 124, yes, some sound is coming, tick, 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 tick. Now sound is getting louder, at 100 sound is getting louder, 80 sound is still louder, 70 sound disappears. So systolic blood pressure is 124 and diastolic blood pressure is 70. Clear? The appearance of sound is while coming down from 160 millimeter of mercury. So appearance of sound is systolic blood pressure and disappearance of sound is diastolic blood pressure. Okay. The sound I am listening with the stethoscope, okay, is called Korotkoff sound. Korotkoff sound, K-O-R-O-T-K-O-F-F. Okay, this is called the Korotkoff sound. Okay, your examiner will ask you, what is Korotkoff sound? Systolic blood pressure measurement by palpatory method and systolic and diastolic blood pressure measurement by auscultatory method. Okay? In palpatory method, we cannot measure diastolic pressure, only systolic pressure. Okay. Yes, now we can go. Okay, now we will come to the classification of hypertension. So, what we call it normal, less than 120 and less than 80. Okay. Less than 120 and less than 80 is the normal blood pressure, optimal. Okay, and normal is up to 130, 120 to 129 and 80 to 84 is also normal. So, the alarming point is from high normal, 130 to 139, 85 to 89, everything is written, I am not reading out. Okay, it's written, I am not reading it out, don't need to write, everything is there in your book. And also actually this classification of hypertension, optimal, normal, high normal, grade 1 hypertension, grade 2 hypertension, grade 3 hypertension and isolated systolic hypertension where only systolic blood pressure is high but the diastolic blood pressure is within the normal range, right. So, it is called isolated systolic hypertension, ISH, isolated systolic hypertension. Okay. So, you need to remember this classification: optimal, normal, high normal, grade 1 hypertension, grade 2 hypertension, grade 3 hypertension and isolated systolic hypertension. So, other than this, we have the hypertensive emergency and hypertensive urgency. Okay. So, that is more than 180 by 110, more than 180 by 110 is called hypertensive urgency, and when it is associated with organ damage. Okay. When it is associated with organ damage, that means injury to heart, injury to kidney, there is problem in the retina, right. So, there may be multiple effects of hypertension in patient's body. So, when it is associated with organ damage, we call it hypertensive emergency, right, and the pressure level is more than 180 by 110. Okay. When it is just more than 80 by 110 without any organ damage, we call it hypertensive urgency, and when it is associated with organ damage, we call it hypertensive emergency. Okay. And we have some specific drug to reduce hypertension quickly to treat the patients of hypertensive emergency and hypertensive urgency. This patient frequently comes in the emergencies, okay, with maybe with the complaint of headache or something like that, okay, and we need to treat the patient immediately by applying some drug or maybe some intravenous drug as well, right. I am not going to the treatment because treatment is not absolutely not required at your level. Okay. So, now you will ask where do I get this data? Okay. So, actually throughout the world we made a convention, or throughout the world we have a body which directs us to follow this. So, this body is either American Heart Association or European Society of Hypertension, okay, and we follow the guidelines created by American Heart Association and European Society of Hypertension collaboratively, right. Okay. So, I can also show you the so, this is the 2018 guideline. So, European Society of Cardiology and European Society of Hypertension guideline for the management of arterial hypertension, and from this guideline only the classification has been taken, and I will request you to remember the classification what I just told: the normal, high normal, optimal, grade 1 hypertension, grade 2 hypertension. Okay, it is taken from this article. Okay. Okay, I am coming to this article. One is the guideline from which it has been taken. Okay, you can get it very easily if you browse. There is a dedicated website for American Heart Association and European Society of Hypertension. You can get it in details. So, this is 2018 guideline, and since then it has not been changed. Okay, and you can get the updated data at their website, American Heart Association and European Society of Hypertension. You just search in Google European Society of Hypertension or American Heart Association. You can go to the home page and check the classification of hypertension and when do we need to treat the patient. So, every details are there. Although I will tell that in fast professional MBBS everything is not required for you, right. but the classification of hypertension is required. What you need to remember is this one, right? Okay. Next, white coat hypertension. These are some questions which are frequently asked during your clinical examination practical. Okay, clinical examination practical, you need to measure blood pressure. Definitely in physiology, you will not be using any patient for you. Okay, you will not, you will maximum you will measure blood pressure of your friend. Okay, your friend, your colleagues, you will measure blood pressure, right? So what is white coat hypertension? So white coat hypertension is office BP in the hypertensive range. Okay, office BP in the hypertensive range, but out of office blood pressure. Office means clinic, in the clinic. Okay, office means in the clinic. So clinic blood pressure or the office blood pressure is within the hypertensive range, either grade 1 or grade 2 hypertension, right? According to the classification. But at home, the pressure is normotensive. Okay, or pressure is normal. ठीक है, मतलब डॉक्टर को देख के उसका प्रेशर बढ़ गया. ठीक है. So this is called white coat hypertension. Okay, and usually patients do not require any antihypertensive medications for this. So very frequently it may happen that the patient is coming to my clinic and I'm checking, yes, his blood pressure is high and I'm prescribing antihypertensive medication. Okay, but actually that was not required. Okay, so there are some flaws in single point measurement of blood pressure, and we don't we don't need to rely on a single point measurement of blood pressure. Okay, now the next question comes, then what will be the accurate method of measurement of blood pressure? Okay, what will be the accurate method of measurement? It's not like that ki everybody will be having white coat hypertension. Okay, all are not tensed, all are not excited, all are not having anxiety by seeing a white coat or a doctor or in the clinic. Okay, a nurse or doctor measuring blood pressure, everybody will not be having hypertension, but a few population will be there whose blood pressure will be raised by seeing a medical setup. Okay, by seeing a nurse or a doctor or a white coat, right? So this is called white coat hypertension. Now next is just opposite is the masked hypertension. Out of office blood pressure in the hypertensive range, but when measured in the office, it is normal. Okay, so this is called masked hypertension. Okay, when the patient is coming to my clinic, I am measuring his blood pressure is normal. Okay, but when the patient is at home, if I monitor blood pressure, 24-hour blood pressure monitor, if I measure patient blood pressure, then he will be having hypertension, and these patients are masked and really risky patients, right? So masked hypertension, and we need to treat, and we need to diagnose the masked hypertension and need to treat the patient, right? Masked hypertension is more common among certain subgroups of the population, including those with diabetes mellitus, those with CKD or chronic kidney disease, and also the patients, obese patients who are having obstructive sleep apnea. Yes, there are multiple factors. I'm coming to subsequent slide. What risk they are having, right? Okay, so this is masked hypertension, right? So masked hypertension is just opposite of white coat hypertension, but white coat hypertension we don't need to treat the patient, okay, just to reduce the anxiety of the patient. If it is anxiety is too much high, we can prescribe some drug as well. Okay, so white coat hypertension and masked hypertension, just opposite. Office BP high, home BP low. Office BP normal, okay, home BP high, right? Okay, now next is okay, I'm showing you the article as well. See, white coat hypertension and masked hypertension. Okay, white coat hypertension refers to the untreated condition in which BP is elevated in the office but is normal when measured by ABPM or HBPM. ABPM is ambulatory blood pressure monitoring. So now the next question is coming, ambulatory blood pressure monitoring. So how to diagnose a patient of hypertension? ठीक है, मेरे क्लिनिक पे एक पेशेंट आ रहा है, मैं उसका प्रेशर मेजर कर रहा हूँ, एंड I can't actually rely on the measurement. Okay, it may be a white coat hypertension or it may be masked hypertension. Then what will be the accurate method to diagnose a patient of hypertension? Okay, patient is coming to your clinic, you are measuring blood pressure and it is 160/90, you can't stamp it is hypertension. You can't, because it is a single point measurement. Okay, at that point it is hypertension, but the patient may not be hypertensive, it may be the effect of white coat, right? Okay, now the next question comes, what will be the most accurate method to measure blood pressure? So if the question comes, what is the most accurate method to diagnose hypertension? Okay, so answer should be invasive. Put a cannula inside the artery, put a cannula inside the carotid artery, okay, and take the blood pressure. But It is invasive. We can't do that. Okay. In the OPD, we can't insert a cannula in the patient's carotid artery or patient aorta and connect it with the manometer and check the blood pressure. It's not possible. So, next question come, yes, then what will be the next non-invasive method which is most accurate to diagnose blood pressure? Okay, non-invasive. The answer is 24 hours ABPM, ambulatory blood pressure monitoring. Okay, ambulatory blood pressure monitoring, ABPM. 24 hours ambulatory blood pressure monitoring. Okay, ABPM provides the average BP reading over a defined period, usually 24 hours. The device is typically programmed to record blood pressure at 15 to 30 minutes interval, and the average BP values are usually provided for daytime, nighttime and 24 hours. Getting my point? I am reading directly from the article, right? See this? ABPM provides average blood pressure reading over a defined period, which is usually 24 hours. Okay, and the device is typically programmed to record blood pressure at 15 to 30 minutes interval. মানে তোমার হাতে একটা device লাগিয়ে দেওয়া হবে, that device will record your blood pressure at an interval of 15 to 30 minutes, every 15 to 30 minutes. Okay, you can wear this and you can roam about, you can sleep with it, okay? You can go to washroom with it, no problem, right? Okay, so you wear the wearable device, okay, wear the wearable device and keep it for 24 hours and finally remove the device after 24 hours, connect it to the computer and it will give you the data throughout the day, okay, and it will also calculate the average blood pressure throughout the day, and depending on that you decide whether the patient is having hypertension or not. Depending on that, you decide whether the patient is optimal or normal or grade 1 hypertension or grade 2 what category. Okay, grade 2 hypertension or isolated systolic hypertension, whatever. So, this is the best method to diagnose the patient of hypertension. Okay, but the device is costly. Okay, you are posted in a rural setup where there is no facility of ABPM. Okay, so what to do? You have only this ghadi and this one is hanging on your neck. Okay, the only things you have is this ghadi and this is hanging on your neck, right? So you need to rely on this. Okay, you measure blood pressure. Yes, if it is hypertensive urgency or emergency, what I just told, you need to treat, because this is white coat hypertension will not be 180 or 110, that range. It is hypertensive emergency or it is hypertensive urgency. Okay, you need to treat the patient, that is different. But if you are seeing a mild or moderate hypertension patient, okay, ask the patient to monitor his blood pressure. Maybe in some medicine shop, or maybe by some nurse, or maybe someone in the society who knows how to measure blood pressure, and take record. Okay, you can ask every day morning you measure your blood pressure, or every day morning and evening you measure your blood pressure. Okay, and you check the record and decide. Okay, so this is the way out only. Otherwise, the best method is always this. Okay, in a developing country like India, yes, ABPM is not available everywhere. But this is the best method, because you need to know the best method, right? And whenever the best method is available, you need to apply that. Okay. So, ABPM or ambulatory blood pressure monitoring is the best method to diagnose hypertension non-invasively. So, in your practical, you will calculate in this way. You will measure blood pressure of your friend, any of your friend. So, take first reading, third reading, first, second reading and third reading, systolic blood pressure, diastolic blood pressure, pulse pressure, and also calculate mean arterial blood pressure. In theory class, I have described how to calculate mean arterial blood pressure, right? It is diastolic blood pressure plus 1/3 of pulse pressure. Okay, diastolic blood pressure plus 1/3 of pulse pressure, or it can be 2/3 of systolic blood pressure plus 1/3 of diastolic blood pressure, right? The formula is same, it will be derived. Okay, so in your practical copy, you need to write this. Okay, in your practical manual, you need to write this. Okay, Define blood pressure. Okay, everybody should purchase own blood pressure machine. This one, ghadi wala. Okay, Aneroid Sphygmomanometer. Everyone should purchase this one. Okay, and a stethoscope of your own. Although maybe college will provide a stethoscope, but don't rely on that. It may not be a good quality, right? So purchase a good quality stethoscope which is very easily available in online stores, okay, Amazon or Flipkart or whatever, right? Purchase one good quality stethoscope and one Aneroid Sphygmomanometer and make habits of measuring blood pressure because it is a practice, okay. So first time what the problem you will be facing is you will squeeze and raise suddenly 50, 60, okay. So make your hand easy, raise at a rate of 10 per second and deflate at a rate of 2 to 3 millimeter per second or at least 5 millimeter of mercury per second, right. So this practice is required, okay. The more you practice, the more you will be confident in measuring blood pressure. Now there are some questions, there are some cross questions in your practical. What is blood pressure? Okay, what do the diastolic and systolic blood pressure depends upon? Okay. So these things will be discussed in theory as well, but still blood pressure is the lateral pressure, okay, which is vertically applied by the blood column over the inner wall of the blood vessels, okay. It is the lateral pressure or the vertical pressure applied by the blood column over the inner wall of blood vessels. This is blood pressure, okay. Blood vessels, okay. Systolic blood pressure depends upon the stroke volume. You know what is stroke volume? What is stroke volume? One contraction, the amount of blood ejected, okay. Usually it is 70 ml, 60 to 70 ml of blood is ejected per pump from left ventricle, okay. Your left ventricle is contracting, amount of blood is ejected. How much amount of blood is ejected per bit? It is called stroke volume, okay. Your systolic blood pressure depends on the stroke volume and the contractility of heart, okay. How forceful the contraction is, okay. How forceful the contraction is. So your systolic blood pressure depends on stroke volume and your diastolic blood pressure depends on resistance, peripheral resistance. Your diastolic blood pressure depends on peripheral resistance, okay. So when your left ventricle is pumping blood, it is sending blood into which circulation? Systemic circulation. So systemic vascular resistance, okay. Systemic vascular resistance, okay. So see this simple example, okay. So I have small arteries in my fingers. These are called digital arteries, okay. Digital arteries, small arteries in my fingers. These are digital arteries, very small arteries, okay. So if I inject some vasodilator over the radial artery or ulnar artery, okay, inject some vasodilator, so that will dilate the blood vessels in my fingers. So now once this is dilated, it will be easy for the left ventricle to pump blood here. If you constrict the blood vessels in the digital artery, the heart needs more force to pump blood into my fingers. So this is peripheral resistance, okay. And this resistance can be overcome by giving some vasodilator drug, okay. And if I inject some drug which will constrict the blood vessel, the heart will need more force to pump the same amount of blood, right. So what I am doing by injecting vasodilator or vasoconstrictor, I am just changing the peripheral resistance, right. So diastolic blood pressure depends on peripheral resistance, right. Systolic blood pressure depends on stroke volume and diastolic blood pressure depends on peripheral resistance. Clear? What are Korotkoff sound? The sound you listen with the stethoscope during measurement of blood pressure by auscultatory method is called the Korotkoff sounds, okay. What is auscultatory gap? Very important. Okay, before that, what are Korotkoff sound? There are 4 phases of Korotkoff sound. Phase 1, phase 2, phase 3, phase 4. There are few phases of Korotkoff sound. Okay, so आप जब ब्लड प्रेशर को रेज करते हो अप टू 160 और अप टू 180 and gradually you release at point of systolic blood pressure, you first listen the sound. Okay, that sound is tapping, tap. Okay, that sound is tapping. Then phase 2 it is called murmur. Okay, then phase 3 it is crisp sound. Then phase 4 is muffle or soft. Okay, so sound quality gradually changes. Okay, so phase 1 tap, murmur, crisp, muffle. Tap, murmur, crisp, muffle. Just remember. Okay, now the thing is, what is the point of diastolic blood pressure? Diastolic blood pressure हम लोग कैसे measure करते हैं? The sound disappears. Okay, but there is a controversy. Okay, there is a big controversy, and that controversy is some clinicians they believe that it is not actually the disappearance of Korotkoff sound which corresponds to diastolic blood pressure. It is actually the muffling or the phase 4, beginning of phase 4, muffling or softening of the sound which corresponds to diastolic blood pressure. Okay, but yes, it is not possible for us, for regular practitioners like us or for you, it will not be easy to differentiate between softening when the sound is getting soft, when muffling is beginning. It is extremely difficult. Okay, until and unless I don't know, even a very good cardiologist also, for him also it is very difficult to diagnose the point of muffling. Okay, so to point out the muffling is a matter of practice, really matter of practice for all practical purpose, because it will not make a big difference. Okay, for all practical purpose, you remember that disappearance of the sound is actually corresponds to diastolic blood pressure. Okay, but very correctly it is the muffling. Okay, so hardly there will be 2 to 3 millimeter difference. Okay, so for all practical purpose, we will consider that disappearance of the sound is Korotkoff sound. But yes, very accurately, it is the muffling which corresponds to diastolic blood pressure. Okay, and there is still now there is a big controversy among the clinician. Few believe that it is the muffling and few clinicians believe that it is the disappearance. Okay. So you can answer in this way whenever the examiner is asking you what corresponds to diastolic blood pressure, you can tell that, sir, for all practical purpose, it is disappearance of Korotkoff sound, but to be very accurately, it is the muffling of the Korotkoff sound. Okay, that makes your answer perfect. Now, what is auscultatory gap? Okay. So, in old hypertensive patients, like our grandparents, right? You have grandparents, right? So, your grandparents or very old aged persons in your family or in your neighborhood, right? Many of them are having hypertension, they are taking antihypertensive drugs, different types of antihypertensive drugs, amlodipine, telmisartan, whatever they are drugs they are taking, okay? But many a times it has been seen that their pressure is not controlled, right? And actually there is no specific cause of hypertension as well, we call it essential hypertension, okay? With the age, our blood pressure increases. Age is a factor, age is a risk factor, okay? So with the age, our blood pressure gets higher, okay? And sometimes it is beyond a certain limit and the patient is classified under grade 1 or grade 2 or grade 3 hypertension, okay? And the classification you have already seen, right? So these patients are called essential hypertension. So what is the pathophysiology behind it? Okay, so this is not a pathology class, but still you need to know a little bit of pathology, what happens here. So if we check the blood vessels in those patients of essential hypertension, so there are some changes, sclerosis, okay, hyaline material deposits in the blood vessel wall and it makes the blood vessels stiff, because blood vessel, in my lecture class I have told that blood vessel has got elastic structure, it has got elastin, it has got collagen and it has stretchability, okay? When blood force flows into it, it stretches and during diastole it can recoil, okay, because of presence of elastic tissues, but this property is lost when the patient is having long standing uncontrolled hypertension. There are some permanent change in the blood vessel which causes sclerosis and hyaline material deposition within the blood vessels. You will study in pathology how it actually looks like, and also you will see the pathology slides under my microscope, what are the changes. So anyway, so major thing is functionally these blood vessels are not stretchable. Okay, so that is why the patients are having high blood pressure, because as the blood vessels are not stretchable, peripheral resistance is high. Okay, peripheral resistance is high, so diastolic blood pressure will also be high. So this is the pathophysiology of hypertension in those patients. So anyway, what will happen, say for example, you have raised blood pressure to 160 and gradually coming down, at 150 you are getting blood pressure, you are getting sound, Korotkoff sound. So your interpretation is systolic blood pressure is 150, but you maybe you have done a mistake, a great mistake. Instead of 160, if you had raised it up to 200, okay, instead of 160, if you had raised it up to 200 and gradually release it, you will see that while releasing, you will get first sound at 180, right? You will get first sound at 180. Then you are getting sound at 170 it disappears. Then again at 160 it appears, right? So there is a gap between 170 to 180 where there is no sound. Okay, and this is called auscultatory gap. Okay, so whenever you are measuring blood pressure in an old individual where you suspect essential hypertension, or maybe the patient is having diabetes, the patient is having chronic kidney disease, okay, so many different comorbid conditions, you need to always keep in your mind that this patient might be having auscultatory gap because of lost elasticity of the blood vessels, and maybe the patient is undergoing some atherosclerotic process, right? So auscultatory gap is due to lost elastic property of the blood vessel, number one, and number two, some atherosclerotic process is going on within the blood vessels. This is the cause of auscultatory gap. So we need to raise the blood pressure initially very high to detect auscultatory gap, and actually this patient is not having blood pressure 170 by something, it is actually 180 by something. Okay, so you need to raise the blood pressure, initial raising of blood pressure, that should be well above the patient's actual systolic blood pressure, so that you can detect the auscultatory gap. Okay, so your exam question, your cross question will be what is auscultatory gap, when it can happen, and what is the cause of auscultatory gap, right? So this is auscultatory gap. It can happen in patients of essential hypertension with diabetes with atherosclerotic process, right? Okay. Achha, what are the factors that affect blood pressure? There are multiple factors. Age is a factor, okay? Alcohol, smoking, okay? Gender is also a factor, right? Associated disease, atherosclerosis, high cholesterol, triglyceride. So there are different factors, okay? We can rather directly see in the article. Okay. So actually there are lots of factors, few factors you need to remember, okay? Everything is not expected from a student of first professional MBBS, everything, this article is available easily, okay, on the internet, or I can also share in your group, okay. So men are more prone to develop hypertension than female, age is a risk factor, smoking is a risk factor, total cholesterol, uric acid, diabetes, overweight, family history of premature cardiovascular disease, family history of early onset hypertension, early onset menopause in female, sedentary lifestyle, okay, sedentary lifestyle means you regularly take fast food, you don't go to the gym, you don't even exercise, right, okay. So sedentary lifestyle, psychological and socioeconomic factors, resting heart rate more than 80, so these are risk factors, right, okay. Okay, this much is these demographic characteristics, this table is important for you, nothing much. What is the most accurate method of blood pressure? ABPM. 24 hours ABPM. Okay? Say it correctly. 24 hours ABPM. Okay. Which principle is this? Bernoulli's principle. Everybody knows Bernoulli's principle, right? Actually, the pressure we measure with the help of sphygmomanometer is the lateral energy. Okay. By physics, we can convert the energy unit to the unit of pressure, right? I can't do it for you, I am not good in physics right now. I was during 10+2. Okay. So this is a blood vessel, right? And here is the pressure we measure, right? This is the pressure, blood pressure we measure, and it is actually the lateral energy. Okay, it is actually the lateral energy, or LE. This lateral energy plus half rho V square plus rho GH is the total energy. Okay, but the height we can ignore when the patient is lying supine. The height we can ignore, so we can ignore this, and we can tell that this lateral energy plus kinetic energy, okay, these two is constant. Correct? Okay. Now, if I constrict somewhere in the blood vessel, at certain point, if I constrict somewhere, what will happen? Speed will increase to make the flow same. Okay? Speed will increase, that means LE plus KE, okay, lateral energy plus kinetic energy is constant, right? So once, what is happening in the constriction? In the constriction, kinetic energy increases. Okay, kinetic energy increases. So to make it constant, lateral energy must decrease. Okay. So if we measure blood pressure within this constriction, what will happen? Blood pressure will be low. So it has got an application, an implication in the development of atherosclerosis. Okay. So atherosclerosis is what? It is deposition of cholesterol foam cells, okay, within the vessel wall. Okay. So atherosclerosis is deposition of cholesterol foam cells over here in the arterial wall. Okay. So practically it makes a constriction in the blood vessel. Okay. So lateral energy here and lateral energy here. Which one will be more? Yes. So pressure will be less here, the area which is involved by atherosclerosis. Okay. The area which is involved by atherosclerosis. So lateral energy here will be low. Here lateral energy will be high. Okay. So pressure will be low within this segment, the segment of artery which is atherosclerosed. Okay. So lateral energy will be less here. Matlab blood pressure, if we measure blood pressure within this segment, blood pressure will be low. And this will further aggravate the process of atherosclerosis. Right, as the pressure is low. Okay. So it will be much more convenient for the atherosclerotic plaque to deposit in the wall, which wall is already involved by atherosclerosis. Okay. So once atherosclerosis, always atherosclerosis. It will keep on deposition, and ultimately the vessel may be blocked. So it makes a vicious cycle. Once atherosclerosis, again atherosclerosis. Right? It makes a vicious cycle, and that is why those patients should take some drugs lifelong to prevent atherosclerosis, to reduce the level of cholesterol, to reduce the function of platelet. So the patient need to take antiplatelet drug or hypolipidemic drugs continuously throughout the year, right? Because atherosclerosis is a progressive process. Okay. If you don't treat it, we can't halt it, right? And ultimately it will block the blood vessel. So here is an implication or application of Bernoulli's principle. Right? There are other applications as well, but this is relevant while teaching you blood pressure measurement. Right? So blood pressure measurement is not a simple topic. Many big things, okay, are there. So blood pressure measurement you are studying right now. in first professional MBBS. Again blood pressure measurement you will study in final year medicine. Okay. Again blood pressure measurement you will study in detail when you will be doing your MD. Okay. And if someone goes to cardiology, again you will be studying blood pressure measurement. So blood pressure measurement is huge. Okay. Don't take it, lightly, right? Okay. But whatever required for your level, not only for your level, also some advanced चीजें मैं आपको यहाँ पर cover कर दिया हूँ, right? So many things are covered here. If you remember today's class, that is everything for you. Okay, maybe up to the days of your MD as well, right? So this much details has been covered, right? But the basic thing which you need to remember as first professional MBBS student, okay, is different methods of measuring blood pressure. What are the precautions to measure blood pressure? What is Korotkoff sound? What is its type? What is auscultatory gap? Okay, what is the size of the blood pressure cuff? Right? These are important for you. And a little classification of hypertension: optimal, normal, grade 1, grade 2, grade 3 and isolated systolic hypertension. Right? So this much is essential for you. इसके ऊपर आप अगर याद रख सकते हो कुछ, that is okay.